Shall we move on to the next speaker? I can already see Dr. Hema Rath being ready with her presentation. So, ma'am, if you can please begin with yours and requesting you to make the slide presentation full screen so that we all have our readability at its best. Thank you.
Very good evening. Today, I'll think before the tea break, I'll be telling about diuretics in acute and chronic heart failure, one of the first and foremost drugs to be used in any kind of heart failure. So let's take a small introduction about how there is congestion in heart failure. That is, natural history of heart failure is characterized by acute decomposition episodes. Signs and symptoms of congestion in heart failure is by extracellular fluid accumulation that increases cardiac filling pressures. That is the integrated results of cardiac systolic and diastolic functions, plasma volume, and venous increase in the venous capacitance. Just a minute, please. Increase as the first compensatory mechanism is neurohormonal activation, which induces a state of increased renal sodium and water retention and causes increased plasma volume. There is increased systemic sympathetic output leading to splanchnic arterial venous constriction, resulting in blood redistribution from splanchnic capacitance vasculature to the central volume. So, the goal of therapy in those patients is a relief of congestion through achieving a state of euvolumia mainly through the use of diuretic therapy. So let's see what is the mechanism of congestion in heart failure. So it's a vicious cycle where increased shift of vascular to the extravascular subcutaneous spaces with salt and water retention will lead to increased LVEDPs, increased PCWP, increased alveolar capillary pressures and fluid transfudations, maximized venous capacitance, redistribution of fluid, all lead to this congestion symptoms in heart failure. So how do we assess prior to the start of any kind of diuretic therapy? Is idea either by the clinical evaluation or the echocardiographic evaluation which we get. Mainly in the first, if he is hospitalized, the clinical evaluation is more promising than that of the echocardiographic evaluation which comes later on. The clinical evaluation is right-sided. If at all we think congestive heart failure, the evidence would be JVP of more than 8 and jugular reflux, hepatomegaly, and there will be a pedal edema with signs and symptoms of dyspnea on exertion if he is a acute and chronic heart failure, and orthopnea, S3 and the rails can be audible. In the echocardiographic evaluation, the right-sided heart failure features are the IVC, which is not collapsible more than 50%, and inspiratory diameter of IVC, if it is less than 12, we can be sure that the volume overload status, and if there is a left-sided features of inflow velocity is more than 50 centimeters, lateral E by E dash more than 12, DT is less than 130. All are the features where there is a features of heart failure. So there are also invasive assessments where we can rely on, that is by the right atrial pressure measurement and pulmonary capillary wedge pressure. But the ESCAPE trial in comparison to serial clinical assessment does not improve in the outcomes if it is monitored even invasively. So what are the common diuretics available in our practice is acetazolamide, loop diuretics, thiazide-like diuretics, and the MRAs. So the doses and maximum recommended doses are known to us. Let us talk only about the furosemide, which is started with 20 to 40 mg and the maximum dosage being 400 to 600 milligrams. So let's quickly revise about the site and mode of actions on the effects of sodium resorption in the nephron at different diuretics. That is the proximal convoluted tubule, where there is an acetazolamide and the SGLT2 inhibitors which act on the carbonic anhydrase inhibitors, and there the sodium and glucose transports. And then the thiazide diuretic, which is in the distal convoluted tubule, and the ascending loop of Henle is the loop diuretics, and then the Vaptans, which are not of help in heart failure, acts on the collecting tubules. So what is the strategy for the loop diuretic therapy? Optimizing looking for the renal dysfunction, fluid accumulation, and hemodynamic status is by direct hemodynamic assessment, systemic and pulmonary congestion evaluation, fluid accumulation in extravascular compartments, monitoring for transient and persistent AKIs. So where does the recommendation of diuretic stand? It is class 1 indication for all decongestion strategies in patients with heart failure who have fluid retention. Diuretics and are recommended to relieve congestion, improve symptoms, and prevent worsening heart failure. Also, with heart failure and congestive symptoms, addition of thiazide to treat with a loop diuretic should be reserved for patients who do not respond to moderate or high dose loop diuretics to minimize electrolyte abnormalities. And in hospitalized patients, the evidence of significant fluid overload should be promptly treated with intravenous loop diuretics to improve symptoms and reduce mortality. And with diuretics, other GDMTs be titrated to goal to resolve clinical evidence of congestion to reduce symptom and rehospitalizations. And for patients requiring diuretic therapy during hospitalization, discharge regimen should include a plan for adjustment of diuretic to decrease rehospitalization. These are the class 1 indications. So what is a decongestion strategy? To start with monitoring the fluid intake and output, standardized daily weight monitoring, clinical signs of congestions as I've discussed, hypoperfusions, and the lab evidence of electrolytes, burn, and creatinine to be monitored. The initial management with the loop diuretics, which is class 1 indication, titrated double IV loop diuretic with the response, which is class 2A, loop diuretic infusion, again a class 2A indication, and a sequential nephron blockage with the additional add-on is class 2A in the initial management. Addition of MRA and low dose dopamine, not as a decongestant therapy, but a class 1 indication for the other disease modifying drug. And on discharge, the treatment plan for the diuretic plan dosage. Titration of diuretics and GDMT during hospitalization to relieve congestion, reduce symptom, and prevent readmission is class 1. IV GTNs may be added as an adjuvant to diuretics for dyspnea in the absence of hypotension. That is class 2B indication. So in the first stage of treatment, the high dose diuretic was not of much use than the usual algorithm chart from the dose trials, which gave definitely a better efficacy, but then increased adverse effect in the higher dose group setups. So what is the fundamental of loop diuretic adaptation is in patients treated with diuretic agents. See the stage at which the patient presents to you, and then the sodium excretion initially increases from 1 to 2, from the point 2 to 3, resulting in a new steady state but a lower extra fluid volume, which was not there in 1. In 1, there was a higher extracellular fluid volume. So what is this pharmacodynamics for which we have to follow with the higher dose and low dose is have a steep dose response curve, meaning that there is a little effect until the threshold is achieved, beyond the ceiling effect is reached. So in normally in acute decompensated heart failure, the loop is down and right. So you have to give a loop diuretics until the ceiling effects have reached for the efficient sodium excretion. So what is the algorithm or the flow chart which is in given the guidelines is total loop diuretic can be administered either as continuous infusion or bolus infusion, and higher dose should be considered in patient with reduced GFR. So how do we start? Congestion with volume overload. Acute treatment plan is loop diuretics. Then start within 1 hour of admission. Starting dose is 1 to 2 times for the previously taking diuretic patients at home, either orally, intravenously, and then if yes, then you start the dosage. If loop diuretics per se has to be given, start with a 20 to 40 mg IV in IV direct bolus or with the divided infusion. And early phase evaluation starts within 1 hour. That is, you check for the spot early evaluation. After 2 hours, spot urine analysis has to be done, and after 6 hours, assess urinary output volume. So it's a good concept of using urinary spot sodium of more than 50 to 70 will give a fair estimate of that for the early response of the diuretics there. And then after 6 hours, if you see there is a persistent congestion, repeat a similar dose of IV diuretic and every 12 hours thereafter. If there is no, then double the increase the dose of diuretics, assess over 6 hours. If there is a fair response, then continue the treatment plan, which is be discussed later in the next slide after 24 hours, or repeat the dose once again. Then what is it after 24 hours? Again, evaluate the urine output. If it is less than 3 to 4 liters or more than 3 to 4 liters, double the loop diuretic dose until maximum loop diuretic dose is given. Continue current dosage until decongestion in the other group if it is achieved. If again assess within 6 hours, if there is less than 100 ml, per hours hourly diuresis. Then the second add-on drugs like thiazides, acetazolamide, and the third line drugs, the SGLT2 inhibitors, can be considered here. And if not, there is a persistent congestion there, then the ultrafiltration is the bailout technique for the acute monitoring of the acute diuresis in the for the decongestion in the heart failure patients. So pre-discharge decongestion evaluation should be continued in as there, but along with that, the other drugs like MRAs and GDMTs have to be monitored depending on the patient's response. So how do you assess for the proper euvolemia after decongestion of the patient? So volumia can be either assessed by the clinical condition or the technical evaluation. Clinically, you see there is orthopnea. Usually in the euvolemic patient, there will be none, and then congested patient, there will be worst. Then JVP less than 8, can be more than 8 or 16 and much higher. Hepatomegaly absent there and there is present. Edema, there is no much of edema, and 6-minute walk test will be more than 400 meters but less than 100 if he is still congested. If you go for the chest X-ray, it is clear here, but interstitial or alveolar edema is there. But better imaging study would be lung ultrasound, that is looking for the B lines when scanning the 28 sites present there, and if it is less than 15, then the patient can be considered euvolemic, or then if it is more than 30 or somewhere in between, you still think he needs a diuretic treatment. So vena cava imaging, a maximum diameter of more than 2.2 and collapsibility less than 50. None of the two, if it is present, think it is euvolemia, and if it is present, you think he is still congested and needs a proper diuretic dosage at the discharge. So it cannot come at the initial stage. It is not so harmful if it is properly monitored and assessed, and the amount of diuretic dosage is adjusted. So what does the ESC? Oh, sorry, it's a typing mistake. It is ESC 2023. The advert randomized to receive intravenous IV acetazolamide or placebo added to standard IV loop diuretic to enhance his efficacy was a non-superiority trial and non-effective trial, except for without meeting the primary endpoints of 3 days decrease symptoms of congestion and increase sodium output. It just reduced the hospital stay for less than 24 hours. Apart from that, it did not show any kind of benefit. Fluoritic trial, that is, it's another trial with tested with hydrochlorothiazides as an add-on therapy, did not give any kind of clinical significance, so not taken in the guidelines. Impulse SGLT2 was tried. Empagliflozin was tried in patients with acute heart failure, but did not show any benefit for decongestion apart from the disease modifying as it did with the other drugs. So the Edward trial, what was the breaking phenomena? It is for the diuretic resistance. Post-loop renal causes which causes the diuretic resistance. In chronic heart failure, it is a class 1 recommendation in chronic heart failure to prevent signs and symptoms of congestion. Again, increasing or decreasing the dosage depending on physical examination, echocardiography, and NT-proBNPs are the markers to increase or titrate or decrease titration of the diuretics apart from the disease modifying drugs. So the class 1, there's still class 1 indication of loop diuretics for the chronic heart failure, even with all ranges of heart failure. And then these are the same drugs which are used for the heart failure, diuretics drugs which are used even for acute heart failure. What about torsemide comparison with furosemide? Furosemide, no better efficacy except for the decreased hospital stay, and did not show any kind of benefit in case of mortality or re-hospitalization. So no difference in the efficacy from furosemide to torsemide, and then total hospitalization was slightly reduced. So in conclusion, as the clinical time should be spent focusing on appropriate diuretic dosage, prioritizing GDMTs, initiation, titration, insight from pragmatic trial designs, and execution from further studies aiming to assess real-world comparative effectiveness. Thank you very much.
Shall we move on to the discussion segment right now? Because we have some 15 minutes time with us. The cases that we have heard so far can now please be discussed by our respected chairpersons and panelists. Thank you.
Shankar here or the chairperson? Devasith has left. But Shankar here or not?
No, I think Dr. Mondal is not here. So you and Dr. Shoma Patro, you'd be here. And then we have a 15-minute break for tea after this. But like, yeah. So you still have 8 minutes in your hand for discussion.
Just want to start in that way. But there is a few of the questions that come in the chat box I have raised. About the IV,
But
also about the SGLT2 with the fifth period of such as the heart failure therapy. In the last slide, the Dr. Hema already indicated actually diuretic therapy along the MRA and SGLT2 along with the RNA, the fourth pillar of success in the heart failure therapy. So there is a question whether we can use the SGLT2Y in terms of heart failure, and we have found there's just what I mean, kidney renal protective effect and just decreasing the interglomerular pressure and just causing the creatinine much less in time scale. So we can use SGLT2, the heart for the DAPA, HF, and decleatommy already proved that in that way is the cause of the similar the renal protective of the heart failure therapy. The one the question the chat box. And this IV amiodarone. So more take up the question of IV amiodarone. So whether you can use the IV amiodarone that the limb control therapy, but it is also myocardially sufficiently depressive. So whether the heart failure we should use the amiodarone in atrial fibrillation or not. Shomo here.
Yes, sir. Actually, IV amiodarone we are giving for our atrial fibrillation patient for a short duration, maximum our mostly with a couple of bolas, then the 24 hours, and most of the time the patient will improve. And during this time, especially the patient is having atrial fibrillation with acute heart failure, we also need to give other vasopressor support most of the time if the patient is not maintaining blood pressure. But if the heart rate is more, the cardiac output will go down. So we need to reduce the rate by any means. And if the patient is hypotensive, then we may need to stop them. But by the way, the question was by one of the colleague that whether we can give cortisone or not. But definitely cortisone has a role, especially if there is a ventricular rate. And sometimes we may need to continue during the oral therapy during the maintenance of the patient who are on atrial fibrillation. But already Dr. Vasavendra has explained that some of the times we may go for, if the rate is not under control, we may need to go for RF ablation, avinodal ablation, and then we need to put the CSP or CRTP or D.
There's only one question from the Basavendra is not here. Basavendra existing? Basavendra here? So just one question to you. Whether in the age of 70, say the age related and hypertensive AF, whether it will opt for the limb control or rate control.
Can you please repeat the question?
Just at the age of 70, age-related atrial fibrillation, when right atrial and left atrial stem is much more and size is much, and the hypertensive patient, whether you opt for rate control or rhythm control.
So that will depend upon whether what is the structural heart disease. If the patient is having structural heart disease, significant valvular involvement, I think rate control in this group will be a fair enough option. However, if the patient is having a structurally more or less normal heart and the symptoms are new onset and we feel that the symptoms have worsened with the development of atrial fibrillation, then we can offer a rhythm control therapy. Now, important things are if the patient is coming to the emergency, then before starting a rhythm control with maybe IV amiodarone, we first have to rule out LA clot.
Yes.
If we are not being able to rule out, at least we should give a prophylactic dose of heparin. And keeping in mind the GFR, overall body weight and other comorbidities, we have to adjust the rate of infusion. And after stabilization,
but the more aged person more than 75, if the rhythm control is attempted by dofetilide or rather IV dronabinol, it advancement is much more prominent than just giving a simple beta blocker along with some digitalist. We can go for it along with some anticoagulant.
So with ibutolide and other agents, the torsedis is more common as compared to amiodarone, and we are more comfortable with amiodarone as of now.
Right. Just one question of discussion, Dr. Hema. regarding whether in the acute heart failure and the left ventricular failure, hypertension or infarct related, whether it will go on for torsemide or the furosemide.
As I told you, sir, there is no better efficacy wise. There is no difference between furosemide and torsemide. But then for follow up, except for the decreased hospital stay, which is also a very minimal percentage. So you can use torsemide or furosemide. Only the dosage difference.
And the same efficacy or efficacy is something
It's the
different?
same efficacy. It is a little better, longer acting. Otherwise, the efficacy wise, it is the same.
Okay, thank you very much, Shubho. We have discussed the chat box questions, and only one. Priyomi is not here. The Priyomi is one question to be for hyperkalemia in the heart failure, the hyperkalemia. Whether CKD, when the creatinine value is more than 6.2, then whether he will use the MRA or not.
Yes, I am here, Dr. Roy.
Oh, you're
Yeah.
here. You're not raising your file.
Yeah.
So whether your creatinine is 6.2 and you're using RNA is much less fatal than MRA, and whether you add back the creatinine is dropping down to 5 or 5.5, then you use the MRA or not.
See, the two molecules, this RNA and this MRA, the both have a standard recommendation. Now, the CKD is basically a defined ball game. CKD totally defined ball game because I think this if you see the RNA group, so even in CKD, though recommendation wise we are not supposed to use when the creatinine clear is less than 25 or creatinine is more than 3, still nephrologists are using it, and we are also actually recommending it nowadays because we have seen the CKD diabetic patient with a reduced ejection fraction, they do have a significant benefit if you continue this RNA. But the issue is again the issue is the potassium. Again the issue is the potassium. So CKD patient on dialysis, there is no problem. On regular standard dialysis, there is no problem.
And if the potassium is,
Yeah,
and if the
no-
potassium around 4 or 4.5.
Yeah. If the patient is on adequate dialysis, there should not be any potassium issue. But if the inadequate dialysis, they're sure there will be potassium issues. So you can continue. But regarding this is very interesting because your MRA, particularly now the Kerendia or the Finerenone is coming in the market, and he has showed robust benefit both kidney outcome and your cardiovascular outcome. If you start in the diabetic patient with your CKD, still in this Finerenone group, the inclusion, if you go through the inclusion criteria, they have excluded patients who have a EGFR of less than 25. So in an advanced stage 5 CKD, still there is no significant recommendation for the use of MRA. If you check the potassium, if I take with the for argument, check for argument, that you can check potassium. Still, even if the EGFR is less than 25, there is no standard recommendation. You can use off level because somebody can argue that it may lead to delay the dialysis, initiation of dialysis. But still, there is no recommendation. Not a standard guideline recommendation to start your MRA, even Kerendia or Finerenone, when the creatinine is around 6. Unless it is an acute renal failure or acute on CKD, then you can actually reduce the creatinine and then restart. So this is the opinion.
Okay, thank you very much. You are conveyed very much. You're well conveyed here. Over to host for the time is up, I think, for the session. Over to host for starting the second session. Subho is already taking some tea break, will be there.
Yeah. Thank you very much.
Yes, now we will
Thank
break
you
for
so
a short break, a tea break or a coffee break. And after that, we will again be back on time at sharp 6 o'clock and we will resume our session. Happy learning. Stay tuned. See you all at right 6.
The tea
Thank
break
you.
is virtual. The tea break is virtual. Okay, Ujjal.
Yeah.
Priyam, tea break is virtual. Hey, Ujjal.